this is an overlapping concept, essentially, right? And oligometastasis basically from MDT, metastatic directed therapy, from MDT standpoint, right? And some use 3, some use 5. And the Oriole trial suggests if you perform MDT to oligometastasis, you improve PFS for this population. The high volume versus low volume, and we talked about is more relevance to the use of chemotherapy. And and the first the chemotherapy agent in hormone-sensitive prostate cancer, which is Charted trial. And that's the first trial opened our eyes, right? All of a sudden, you have a 17 months of improvement over survival by simply using a old chemotherapy agent, docetaxel. And later on, people did subset analysis and find out those with high volume, meaning 4 or more bony metastases, benefit more compared to those with a low volume. So that's the high volume versus low volume discussion started. And so there's a scenario, and because of the PSMA PET scan, and let's say PSMA PET scan detect much more lesions than the conventional CT scan and bone scan. And based on conventional CT scan, a bone scan, you think this patient belongs to the low volume. Well, based on the PSMA PET scan, you see much more, many more lesions. How would you treat this scenario? Would you treat the patient with triplet approach, or?
Yeah, I know we don't have data to support it, but I think I would favor, like as you said, you can't unsee a PET scan, right? You can't not give, if it's a fit patient, younger patient, you want to give them the best chance. Mm-hmm. You know, we know the triplet therapy improves overall survival, progression-free survival. You're adding benefit, right? I would say.
Yeah, I agree, generally speaking. I mean, there's, sometimes it can be helpful to then look at the CAT scan after the PET scan. And sometimes, you actually do see changes in the bone that perhaps, that now that you've been alerted to those areas, there really are definitive sclerotic changes that just were missed before. And that's definitely a case where I would treat the patient with docetaxel. If we're talking about, some very tiny lymph nodes, for example, let's just say that they have, lymph nodes in the thorax, and there's a few bone lesions which are kind of questionable, then I might back off. If the patient, especially if the patient is more elderly, and I was a little nervous about doing chemo to begin with, and I think that the best data we have for survival is certainly with the use of triplet, with PIS1 and Arasens, but we also know that chemotherapy carries toxicity. And we also know that outcomes with ARPI and ADT alone are also excellent. So in those borderline cases, it becomes a patient-centered discussion, as it always should be, about goals of care.
Right. So there's no direct comparison between ADT and ARPI and the triplet, right?
That's correct. There's never been a direct comparison, basically assessing whether chemo really adds much. We know that an ARPI should always be added to docetaxel when treating, but again, whether docetaxel adds much is not clear. There's an alliance trial that's been, being developed trying to compare these two, which is one of the largest questions in metastatic castration-sensitive disease. But I would say in general, if the patient is fit, the best data we have suggests that chemotherapy has significant benefit in high-volume disease.
So now, since we talked about triplet approach, and there are 2 major clinical trials, the PIS1, the French study, using ADT plus docetaxel as a backbone compared to abiraterone versus placebo. that showed overall survival benefit. The Arsens is a North America trial, and using ADT plus docetaxel compare darolutamide versus placebo. Both show improvement of overall survival in patients with hormone-sensitive metastatic prostate cancer. PIS1 mostly based on de novo metastatic prostate cancer. And in Arsens, I would say majority of the patients are those with de novo metastatic prostate cancer, but there's small fraction of patients actually had metastatic metastatic prostate cancer, meaning patient was treated with local disease in the past and later on developed metastatic disease and enrolled in the study. Okay, so the study basically demonstrate the benefit of adding ARPI and abiraterone in this case of PIS1 and darolutamide in the setting of Arsens trial. And so now we learned that in hormone-sensitive prostate cancer, trials after trials after trials, and started from Arches and Latitude and Stampede trial platform, and got abiraterone approved first, followed by Arches Enzamat for enzalutamide, Titan for apalutamide, and the most recent approval is darolutamide based on Aranote. And Aranote is a phase 3 trial actually conducted outside North America, and using ADT plus darolutamide versus ADT plus placebo. It did show overall survival it did show RPFS benefit. The overall survival data is not mature, and but I think it just got approval by FDA. And so, what do you think with the new approval of darolutamide based on the Aranote? And Dr. Raj?
Yeah, it's in my experience, anecdotally, and it's a conception that darolutamide is tolerated better than the other three known as a doublet, and we have as also evidencing the triplet with the Arsens trial. So, but it's a tough thing for community oncologists to see which is the best fit for a patient. For example, abiraterone and prednisone, entozolamide, apalutamide, darolutamide, it's difficult to differentiate. I think generally oncologists are creatures of habit, and what they are used to, they tend to treat. So it's hard. I mean, side effect profile is critical, I guess, and there is some suggestion that abiraterone has some cardiovascular downstream effects, and you take prednisone for a long time. So it's hard for community oncology.
Right. That's a tough part. Abby is like the prednisone,
Right.
taking it for that long.
So now we compare different ARPI, abiraterone, enzalutamide, apalutamide, and darolutamide. In practice, Dr. Haq.
So I still, because abiraterone has, I think cost-wise, it's still covered well. I think it's generic now. But I think overall side of, especially for older patients, I think one of the lutamide probably is a better choice, and I think that's going to, it's going to change practice. I think you'll move away from.
So that's a very good point. There's a recent presentation, I think, in ASCO. There's a meta-analysis called Stopgap, and which I think analyzed about 10, 11 phase 3 clinical trials and compare all the trials in terms of efficacy. So the conclusion is that adding ARPI plus ADT certainly improve overall survival, everybody knows. And the surprise finding from the study is that when they look at the patient of different age, abiraterone did not seem to serve any benefit for men older than the age of 75. And what do you think of that data, Alex?
So, right, so I think that's really important. And when I'm considering which, agent to use, then that's a big consideration. So for men above the age of 75, I will generally stray away from using abiraterone because of not only the stopgap data, but also because the hypertension can be quite difficult to manage. So I look at age. I also look at, are they on multiple antihypertensives? Many patients, I mean, the data will show 30 to 40% of patients, but in my experience, even more than that, end up needing intensification of their antihypertensive regimen. And if somebody's on one agent already, then we have a little room. But if they're already on 3 antihypertensives, then we're gonna get into a very difficult spot where I'm adding, diuretics in patients who are already having polyuria, and or adding a fourth antihypertensive, which is really hard. So in those patients, I'll tend to want to use one of the other drugs. The other question is somewhat of side effect profile. Abiraterone has very few drug-drug interactions, which is helpful, though needs to be taken with prednisone, which introduces the whole issue of steroid-related toxicity. The nice thing about darolutamide in particular is that darolutamide does not have the CYP3A4 interactions that enzalutamide and apalutamide do. It is not a problem to be given with DOACs, which is helpful. And it doesn't have, to the same degree, the brain fog seen with Xtandi and or the rash seen with apalutamide. So, in general, it is a pretty easy drug to use. In the metastatic setting, then, especially for older men, if I'm going to give a triplet, then I think darolutamide in general is better tolerated. There are some drug interactions, for OP1 relevant drug interactions with some of the ARBs, like irbesartan and valsartan. There are interactions with statins, with torvastatin and Crestor. So we have to keep an eye on those sorts of things. But I think that Aranote will change things, certainly, in that when we are choosing a doublet, we now have evidence to support the use of darolutamide.
But what do you think about the data so far only show RPFS benefit without the overall survival benefit?
Yeah, and the truth is that we have some overall survival benefit, but certainly it's not mature, and the confidence interval does is crossing the boundary. So I think it's an interesting question of is darolutamide as effective for overall survival? I think it depends on the setting and, to a certain extent, goals of care. If you have a patient who sort of prizes overall survival above all else, even perhaps at the risk of some added toxicity, perhaps we will shift towards Dara towards APA or Enza, and vice versa. If the quality of life is more important, perhaps we'll choose Dara.